Welcome to another episode of Dr. Doctor, the award-winning radio show and podcast featuring your physician host, Dr. Tom McGovern.
And I'm Dr. Chris Stroud, and this is the show where we and our guests will discuss relevant health-related topics, and always from an authentically Catholic perspective. Now, Dr. Doctor is brought to you in part by the very generous underwriting of our friends at CMF Curo. You can learn more at mycatholichealthcare.org. Live your Catholic faith in your healthcare with CMF Curo.
Today, our guest will be heard across the EWTN Global Catholic Radio Network. Joining us will be Dr. Cathay Schanzer, an ophthalmologist, to reignite our specialty focus series with an emphasis on focus. See what I did there, Chris?
Yes, how could anyone miss what you did there? Except I think maybe I don't have the vision to properly see what you did there. Or we might say the eyes have it, perhaps.
Don't they always? So, Chris, what makes this topic so important for our listeners?
That's easy, Tom. Everybody listening probably has eyes. If they don't have two, they probably have one. Or if they don't even have one that's working, they probably did at some time. So, the ability to see our environment, it's a critical, basic, universal part of being a human being. I cannot imagine the trauma of losing my vision. And if I think about it, the first thing that comes to mind is I would never see the faces of my grandchildren yet to be born. And I just can't imagine that. We work as human animals, sensing and testing our environment constantly. We're always probing and scanning and, looking for danger. And our eyes play an incredibly important part in getting that job done. Everything, if you think about that, of all the things I should say that we learned through the pandemic and through the covered faces of masks, is that it's tough to understand people sometimes when you can't see their face.
Yes.
There's so much communication that goes on behind those masks. I flew this weekend. It was so nice to see the people's faces around me on the airplane. So suffice it to say, vision is a big deal to being human. So those healthcare providers, like our guest, who take care of people's vision, they become a big deal right out of the gate. So I'm really looking forward to hearing more from her. And I'm sure we'll hear from her some of the very common conditions that can cause problems with the eye, like diabetes and high blood pressure, that if left unattended can actually damage the eyes in some cases in a way that's permanent. So we'll learn more about how the eyes can be the window to the soul, as an attending of mine in medical school used to say. So we meet our eyes. So listeners, tune in, get comfortable, and pay close attention.
Amen. And, before I chose dermatology, I initially wanted to be a family physician. Then I realized I wasn't happy knowing nothing about everything. So I figured I'd rather know everything about nothing, or a small area. And before dermatology, I was really wrestling between ophthalmology and dermatology. And something I think they have in common is that patients know when they're getting better. With the skin, they know when they're better and they're really happy about it. Well, the same thing with your vision. If you can't see, and they have a lot of really cool toys. I think more than just about any other specialty. I thought that was wonderful, but it's a really tiny area in which you get to use all those toys. But yeah, I did them back to back in my internship year. I loved both rotations. I even went to the Armed Forces Institute of pathology course on ophthalmology, which was really cool, knowing what's going wrong. But it was just a gut decision. So I think ophthalmology is an absolutely wonderful specialty.
I'll tell you, my brush with ophthalmology during my residency training in obstetrics and gynecology was not quite as impressive as yours, perhaps. I remember, though, very clearly once in a big grand rounds lecture, we had an ophthalmology attending that was lecturing. And he said something along the lines of, when I look into a patient's eyes, I'm looking into their soul. And then he called on me as the sole gynecologist in the room. And he said, when you look at your patients, what do you see? And I said, well, not their eyes, probably not their soul. So that was my experience with the specialty. But I think of all the specialties, they do have some of the coolest tools. I just got my eyes checked recently. And, it used to be a secret what's going on inside the eye when they would come at you with those fancy little ophthalmoscopes. But now it's projected on a big LED screen that everybody can see.
Wow.
It's no longer a mystery, and it is fascinating to see the little blood vessels pulsating in the very back of your eye.
There's a subspecialty of ophthalmology that I deal with in most surgery, and that's oculoplastic surgery. A lot of
Uh,
people probably don't realize there is a subspecialty of ophthalmology dealing with plastic surgery repair of the eyes, because a lot of plastic surgeons, general plastic surgeons, don't even have the experience. Because in the last several months, I have ended up removing two entire lower eyelids on patients for skin cancer. I mean, not just the
wow.
skin, but even into the muscle and what's called the tarsal plate below it. Yeah.
Wow.
And then, I mean, the people that can repair that, they are amazing.
Wow, that's impressive. Yeah, I'm really looking forward to learning a lot more about this amazing specialty from our guest. But at this point, it's time to jump forward with a medical trivia question, Tom. I know our listeners can't wait to see what you have to offer.
Yes, the category for today is cranial nerves. So,
Mm,
for those who are unaware, there are 12 pairs of nerves that connect directly between the brain and their end organ. And the end organ could be the eye, could be the nose, could be some muscles. Okay. So, they don't have to relay through the spinal cord like most of our other nerves. The first cranial nerve, for instance, is called the olfactory nerve and transmits sensations of smell. So, how many of the 12 cranial nerves, we know one isn't, so it's 11 or less, how many of the 12 cranial nerves are involved with vision and eye function? And as a clue, I'm going to give you a little mnemonic. On old Olympus' towering top, a Finnan German viewed some hops. And if you don't know what that means, it's okay, because we're going to explain it to you at the end of the show. But right after the break on Dr. Doctor, we'll be back with Dr. Cathay Schanzer and ophthalmology. We're back on Dr. Doctor with our guest, Cathay Schanzer. She's a Texan by birth. She stayed there for medical school at UT in Houston. She did her residency at Baylor College of Medicine in Houston in ophthalmology. She has a large eye surgery practice in Sayre, Pennsylvania. She's been married to 43 years to Tom, has 8 adopted children, 21 grandchildren, probably a high energy level. She also does just a little bit of mission work twice a year, and we'll talk somewhat more about that as we get through. And little is an understatement. And you can also see Cathy and her husband Tom on YouTube at a site which probably won't make sense to you till later, but it's www.thegiftsofsarabu.com, and Sarabu is Serabu. I probably pronounced it wrong, but she'll correct us later. Cathy, welcome to Dr. Doctor.
Thank you so much for having me. It sounds like this is going to be a very interesting little time together.
So, Cathy, of all the things you could do, clearly, there was no room for you in OBGYN or dermatology. So, so you made the decision to become an ophthalmologist. After 4 grueling years of medical school, you kept going to do that. So, help us and our listeners understand what drew you to this specialty.
Okay, that's really not too hard. I thought I wanted to be primary care, sort of like you guys have discussed already. And I did an internship in pediatrics. And as a medical student, because I was in Houston, we went down to the border a lot and worked in clinics down there. So I was really sure this is what God was calling me to do. During my time to apply for a residency, my husband was adamant that we needed to look at things that weren't quite as demanding as primary care. So I decided, okay, well, I would look into ophthalmology, because in ophthalmology, you have to apply for your internship and your residency at the same time. So you have to get both of those
Right,
lined up.
right,
And then your internship can be in anything. It can be in surgery or peds or internal medicine or whatever. And so I started
right.
out in pediatrics, and I got I did fine in the beginning, but then I had to spend several consecutive months at MD Anderson Hospital and watch children die. And it was that time
Oh,
that I knew I could not watch children die. And since I already
wow.
had the ophthalmology program in my back pocket, I signed my letter of intent in December or January of that year. and jumped in. I went to our, everybody's got some type of counselor at school. I went to the counselor and I said, I don't know what to do. I'm getting depressed over these kids that are dying. I've got the ophthalmology thing kind of hanging in there. I don't know what to do, and I don't want to just ask which is better, one or two, for the rest of my life. Like when you have refractions and stuff. And he was so he was so kind, and he said, "Our Lord Jesus Christ cured the blind. Could you think of not
Mm.
a better thing to do?" And I went, "I think that's talking to me." And this was not a Catholic, this was not a Catholic program. This was University of
Wow.
Texas. So I accepted my ophthalmology program, and I have not looked back. I have loved it from the very start. It is absolutely the best subspecialty, far better than dermatology. Um, and it just allows you to take care of kids, adults, neonates,
Yep.
sick people. It allows you to go on mission trips and actually restore sight to the blind and change people's
Wow.
lives and free people up from the poverty trap that they're in. It's just the most amazing thing you could do. I love it.
Now, Cathy, I was in medical school, I hate to say for our listeners, but in the late 80s, early 90s. And it seems like if I remember right, ophthalmology was crazy popular. And then it sort of went away almost. And then it came back in huge popularity. And is it true that that was around the time of the sort of advent of LASIK surgery?
That's true. So some of the problem has to do with just the dexterity. So some people kind of got knocked out because they could not do surgery under a microscope with their hands, and you got to use your
Mm.
feet at the same time. So you got to be able to use the microscope pedal, the phaco machine pedal, or the laser pedal, or whatever other thing you're doing. So both hands, both feet are working constantly. So if you took piano, or know how to play the organ,
Yay.
yeah,
The organ, yeah.
exactly. So that a lot of people
Are
fell
you
out.
are you a pianist, Kathy? Are you a
Well,
pianist?
I am sort of. I quit playing for a long time, but since I moved up here to Pennsylvania, I've started taking lessons again, and it's been so much fun. And I have just the coolest teacher. He's just so fun. So
Now,
yeah.
as we mentioned in the intro, Cathy, you guys in ophthalmology have some pretty remarkable technology. Um, Tell us about, your favorite at least, but tell us about some of the technology in your specialty.
All right. So clinically, we've got certain things that we use, like the slit lamp, which lets you look in the front of the eye at the cornea, look at a cataract, allows you to check the pressure. That's kind of one of our just basics, which we've had a long time. Got ophthalmoscopes, both a direct and indirect. That lets you look on the inside of the eye. So if you're looking for somebody that may have diabetic retinopathy or glaucoma, or maybe changes due to their hypertension, or even things like
Mm,
anemia, leukemia can show up in the retina. So those are sort of like the ones that we use like every single day. But then we've got
mm,
some fun lasers. So we've got a YAG laser that will help us to treat people with glaucoma, or to open the little posterior capsule after they've had cataract surgery. We have SLT laser and argon lasers that are used for treating glaucoma. And then there's
mm,
also the ones that we use for refractive surgery, so the excimer and the femtosecond. And then more recently, the laser the laser adjustable lens has been approved. So an intraocular lens can be placed inside of the eye, and then you use a laser to alter it. So that's just really cool technology. In addition,
Oh
we
my goodness.
Okay, you started me. Okay, so I'm not even getting there. So we also have things like for glaucoma. So we have the minimally invasive glaucoma surgery. So we have all these little devices that while we're in there doing their cataract surgery, we can just slip them into the drain part of the eye and help their glaucoma and get them off of some of the drops. So that's been really cool. And then there's all this different stuff. The big thing is dry eye. So I have all these different things to diagnose dry eye, like MMP3s, which will show inflammation, how to check the osmolarity. And then there's treatments like where you can actually put special instruments, machines in that you put on their lids to get the meibomian glands to work better. there's new things like the OCT, so we can look at the retina or the cornea. So the cornea has all these different layers, and we can use this to look at the cornea both in the clinic, or if I've done a corneal transplant and I want to look at to see if the cornea is attached to the patient's cornea, so I can get into all the different types of corneal transplants. But the
Wow.
OCT allows me to be sure that that's attached, and the OCT is used for retina as well. So there's just there's wavefront aberrometry, there's tomography, topography. It just goes on and on. We
Wow.
just do lots of stuff.
Wow, Cathy. Now, you said, if I heard you right, while we're in there, we can just do this and this and this. So I'll bet a lot of listeners like me are struggling to understand what you mean by in there.
Okay,
How,
so while we're
how can you be inside someone's eye?
Oh, quite easily. So, we're in there taking out their cataract. So remember, the cataract is in a bag. We open the front of the bag, we clean out the cataract, and we put an intraocular lens in the bag. While we're doing that procedure, we can go through that same incision and put a little, it's a tiny, tiny device. There are a number of them. There's the hydrus, there's the eye stent, there's a number of them that we can go in and put in the trabecular meshwork, or we can actually remove some of the trabecular meshwork to aid the outflow of the fluid for those people who have glaucoma. So if you have a patient who's got cataracts and they're on 2 or 3 glaucoma meds, if you can do one of these, we call it MIGS, minimally invasive glaucoma surgery. If you can put a MIG in there while you're in surgery doing their cataracts, you can knock off some of their medicines. And on the elderly, it's already hard enough to get those drops in.
Now, I think you've made a mistake. MIGS stands for minimally invasive gynecologic surgery.
No, no, no,
Um,
no, no. I
now,
think you're quite wrong.
as a gynecologist, I stick some things in some funny places, but I just can't imagine putting something inside someone's eye. And I'll bet a lot of our listeners feel the same. Is that hard to do?
Well, it is if you don't know what you're doing. It's like anything. Is it hard to drive a car if you don't know what you're doing? I mean, obviously, you have to be trained to do this. You're trained to do the cataract surgery properly. You're trained to do the insertion of these devices properly. And when you're trained to do them properly, your outcomes are very good. And you really have to be
Mm.
careful with all the measurements preoperatively, everything that you're doing. It's not just once and you're done. I mean, we're firm believers in measure twice and cut once, so we're very careful with all our measurements.
Cathy, one of the things that I saw done that really freaked me out the first time I saw it is taking a huge needle and injecting anesthetic behind the eyeball by going, between the eyeball and the lower eyelid. Is that a thing?
That is a thing, but we don't do it very often in the United States of America. The reason being, we mostly treat our patients in cataract surgery with IV sedation and topical anesthesia. If we're going to be
Mm.
doing more
Ah,
extensive surgery, like the what's called manual small incision cataract surgery, which is what we do in Africa, then we will do a block, a peribulbar block. So that makes it so
okay.
that they're not feeling so much. But in the United States, if I do 2,000 cataracts a year, I would say maybe 5 of them would get the retrobulbar injection.
Got it. So, how many years of training did it take after your internship in pediatrics to do what you do today?
So after your internship, you then do the 3 years of residency, and then it's another 1 to 2 years of fellowship, depending on which subspecialty. And so I actually did not do a fellowship because by that point I had 3 kids, and my husband was involved in a startup company, and we needed somebody to make some money. So I just went out and started practicing. That was me, the money maker.
So, what
So
are some of the subspecialty options that ophthalmologists can do
okay, so
besides oculoplastic surgery?
I'm considered comprehensive, which means that I do a little bit of glaucoma, I do lots of cataracts, I do some refractive, I do a lot of different types of lasers. But you can also be cornea, which means that you only do corneal transplants and refractive
Mm.
surgery like LASIK and PRK. You could be just an anterior segment, so that means that you do the cornea stuff and do glaucoma stuff, but you don't do the refractive surgery. Then there's also
Hmm.
glaucoma specialist and vitreoretinal specialist and glaucoma specialist and uveitic specialist and the pediatric strabismus specialist. And the oculoplastics also are the ones that do the oncology, like you were already discussing. And just recently, they started a subspecialty called presbyopia, which, after you get 40 and your arms
Wow.
your arm's not long enough, that's called
Yes.
presbyopia.
Yes.
Okay.
Yes.
So they
Yes.
started a subspecialty with that because we now have so many new things that go along with that.
Hmm.
Ooh, and then there's neuro ophthalmology
Oh, I left
too,
out
right?
neuro. You're correct. I left out neuro. There is neuro ophthalmology.
So,
How can I do that?
okay, well, since those of us on this show all are dealing with presbyopia, tell our
Hmm.
listeners what's new, because I made it till age 49 before I bought reading glasses. Okay, so
Mhm.
is there an option for those of us with presbyopia besides reading glasses?
Well, actually, there is. The new drop that just got approved is called Vuity, Vuity. It's a pilocarpine, and so it constricts the pupil. And what happens with presbyopia is that the lens of your eye, just kind of stiffens up. When you're a kid, it goes from fat to skinny, fat, skinny, fat, skinny,
Yep.
fat, skinny, as you're focusing far, near, far, near, far, near. Then as we get older, it just loses that elasticity and it just sort of thickens and
Right.
hardens. And so the Vuity is a drop that can help. It you can use it several times a day. It helps mostly at night. People tend to have more trouble at night. The most, to me, that's just sort of temporary. To me, looking at some of the new multifocal intraocular lenses is really the way to go. Now, my motto is a chance to cut is a chance to cure. So obviously, that's why I would like all of the intraocular lenses, but we have multifocal intraocular lenses. So we have some lenses that will give you near, intermediate, and distance. So it's like a trifocal. We also, and there's
Hmm.
bunches of different ones of that. And then there's now the newest one is called an extended depth of focus. So it's just got a little elevated area on it and it stretches the wavelength. So it gives you computer distance and far away distance. The only downside of that one is it doesn't give you real close vision, whereas the trifocal one gives you up close, intermediate, and far. And so those frequently when people start complaining that they can't see up close and they want to consider that, we don't have to wait for them to develop a cataract. We can do what's called a refractive lens exchange. So we're taking out their lens, and frequently they've already started. By the time it aggravates you, you've already started having a cataract. And when we do glare testing, frequently we find out that you're really having more trouble than you thought you were having because you're having glare at night or oncoming headlights or trying to drive in the snow or the rain or the fog. And so during those times, that tells us you already have sort of a dysmorphic lens, not hasn't really gone into the cataract form. And we actually have another instrument called the pentacam that will actually measure the changes in the lens of your eye so that you can demonstrate to somebody if they go, well, I'm not quite ready for surgery yet. You can show them the little peak now, and then they come back in 6 months. You show them that the peak has worsened. And they're like, well, it seemed like it was worse, but my visual acuity is the same. And it's because the lens is actually changing during that time.
Wow. So I have a feeling that a typical week or a typical day for you involves a lot of energy. Um, but give us a sense of what a day in the life of an ophthalmologist is like.
Well, right now I'm doing surgery 2 days out of the week, and I'm in clinic 3 days of the week, and it's soon going to move. It's soon going to flip where I'm in surgery 3 days and clinic 2 days because we just can't keep up with the demand. When I joined this group up here, when I moved out of Tennessee and moved up here, it was to help with the demand. There's just so many patients even here that have cataracts and need surgery. So the typical day, if I'm in the clinic, will consist usually of post-ops as well as cataract evals. meaning that they come in, we do all their measurements for their cataract surgery. So that's going to be measuring their corneal surface, the astigmatism, the length of the eye, the anterior chamber depth, which is from the cornea to the iris, looking at the lens thickness, those sorts of measurements that all get thrown into a formula to help us know what intraocular lens would be good for them. In addition, we can look at the astigmatism and know whether or not we should offer them a toric lens. So a toric intraocular lens will take care of the astigmatism. And the upgraded lens I mentioned before, they will also take care of astigmatism. So if you want to get your astigmatism fixed and get rid of your readers all at the same time, we got you.
Oh,
Well,
so how many?
I'm not sure we know what a day is like, because that sounded like a year to me. But we'll take it. We'll take it on good faith that it was a day in the life.
So
But
how
then,
many patients will you operate on a given day, and what age range of patients do you see in a given day?
okay, so usually in a full day of surgery, it's 30 patients, and that will be a combination of routine cataracts as well as the upgraded lenses. And the reason I bring up the upgraded lenses is because they take more time. If we're putting in a toric lens, it's got to be or even the trifocal lens that's going to correct astigmatism. It has to be lined up exactly according to the axis
Right.
of that person's astigmatism. So you got to do measurements. You got to measure the patient sitting up so you get them straight. Then you lay them down and you do more measurements. So those take longer. But we do a combination of those. And then on some days we throw in some corneal procedures into the cataract. So if someone has what's called Fuchs dystrophy, where the endothelium of the cornea is not working anymore, we remove that layer and we put in a real thin layer. Now, years before, like when I was in training, we would do a full thickness corneal transplant, and it would take these people a year to recover. Now we can take out the old
Wow.
tissue, put in the
Mm.
new tissue, and they'll be recovered within a month or two. So, and it
Wow.
doesn't induce astigmatism because it's only that inside surface of the cornea that we're working with.
Wow, Cathy, we'll change gears a bit. Tom and I recently did an episode on diseases of the Bible, and no surprise, he chose leprosy. But as you think about that, what are your favorite passages in the Bible dealing with eyes, and why do those appeal to you?
Oh, my very favorite is in the Acts of the Apostles when Paul has the scales fall from his eyes when he goes
Yes.
out to spread the word. I love that. And since we're just still within the Easter season, I always think about that. The other one, which is so funny because a patient brought this one to me after I had done LASIK surgery on her, and she needed to have an enhancement. So it's the one where the Jesus is healing the blind, and then he says,
Oh,
"What do you see?"
yes.
He says, "They're walking like trees."
Two
So
times.
then,
Yes.
yes,
Yes.
exactly. And so then finally, after he does his quote little enhancement, then he can see clearly.
Just
So
touch
my
up. Yeah.
patient actually brings in this quote from the Bible to say, even Jesus had to do an enhancement. Don't feel bad that I needed to have an enhancement after my LASIK. But
And Cathy, since you're the expert, what is the most likely disease that Paul had that caused his blindness? Is it possible to make a guess?
well, to have scales fall from your eyes, that's just I don't know. I just because it's, the cataracts are inside of the eye. The things that are on the
Right.
outside of the eye that drop the vision would be something like a pterygium that grows over the cornea, but that's not going to just
Right.
fall off. I mean, I guess
He
God
has a
can make it fall
scale,
off, but
and trachoma doesn't do that. Chlamydia trachomatis doesn't do that.
no, it causes scarring, but it's not going to just fall off the eye.
Ah,
Yeah, but it
yeah.
does
So
cause
it
some
was
scarring.
miraculous.
Yeah, very miraculous. Yes. And then there's lots of times, in the Bible where Jesus just cured the blind. I mean, he's getting the blind with
That's
putting
all.
mud on their eyes, spitting on them, all the things that I tell my patients not to do. Don't get mud on your eye. Don't spit in your eye. Wash your hands. And then Jesus does it
Yes.
and gets away with it.
Well, Cathy,
Oh,
that sounds like a perfect time to take a break. We'll be right back with more miracles of the eye on Dr. Doctor. Well, welcome back to Dr. Doctor. We're trying to see our way through this discussion of ophthalmology. So, Cathy, continuing, I think all of our listeners, when they hear ophthalmology, they're thinking about LASIK surgery. I mean, certainly you can't drive down the street without seeing a billboard about it. Help us understand what is it and what's the big deal about LASIK?
All right. Well, LASIK will help you if you have nearsightedness, farsightedness, or astigmatism. And what
Ah,
happens with LASIK is that we use a femtosecond laser, so one of the lasers we talked about earlier, to make a flap. And the great thing about the femtosecond laser is it allows us to make a flap much thinner than the old keratomes that we used a number of years ago. So if you make a thinner flap, that gives you more corneal tissue to work with, because the one thing you don't want to do is to ablate so much of the tissue that you weaken the structural integrity of the eye. So you make a
hmm,
flap, lift the flap, and then treat directly onto the stroma of the cornea, and then put the flap back down. And the
hmm.
great thing about that is you may have some foreign body sensation for a day, but usually by post-op day one, you're pretty close to where you're going to be 2020, maybe 2025, but most people see really well. The other thing is PRK, where you just remove the surface of the cornea, the epithelium. It's like the skin layer of the cornea. You just scrape that away and treat directly on the cornea. And the reason you might do that is because the cornea is not thick enough. And again, you want to maintain that structural integrity. The other thing you can do as a refractive procedure is implantable contact lens. So there's a tiny lens that you leave the patient with their own natural lens, as opposed
Hmm.
to someone whose lens has become like a cataract. So you leave them with that, and you put the implantable contact lens. It's a polymer lens made out of a polymer material, and you put that in the eye behind the iris, but in front. So it's going behind the iris in front of the lens, so they can't really see it. And that's been huge for people who have too much correction for their cornea. So they don't have enough corneal tissue. There's not enough, not enough real estate there to ablate that much. So you can put the ICL into the eye, and that will correct their vision. And you may have other reasons for wanting to use that. Maybe they've got some other corneal problem. I did the ICL on one of my daughters who was a Winnebago Indian, and she has really, really bad scarring. I mean, so I was afraid to do ablation on her cornea for fear she would get hazing and scarring. Don't rub your eyes.
Hmm.
Um, and so, I
What's
put
the alternative?
yeah, I put the ICL in her. But I've got another kid. One of my sons was going to be heading off to the service, and I was afraid, if he lost his. He used to call them birth control glasses that the army issued because they were so ugly.
Yes, yes.
And so I was afraid he'd be out somewhere and lose his glasses and not be able to
Hmm.
find his way back to camp or whatever. So I did LASIK on him before he headed off to the army. Um,
Hmm.
so, um, you
What
know,
a
there,
great mom.
there you go. But I mean, those are some of the refractive options that we have. And of course, the intraocular lenses, as we've discussed, that's a refractive procedure if you're doing it when there's not a cataract.
Wow.
Cathy, what are some stories? I mean, you've already been telling us these little stories, but what are some of your favorite stories of, bringing joy to your life through your patient care?
Oh my gosh, there's so many. For a while,
Right.
I was working in San Antonio just once a month. So the University of Incarnate Word, which is a
Yes.
Catholic university,
Hmm.
and it has the Rosenberg School of Optometry. They had gotten a grant to build a building in the poorest part of San Antonio. It's where most people won't even go in that area. And they were looking for somebody to come to that area and help them out. So, because one of my friends was there, they said, well, I know somebody who does mission work all the time. She can handle this. So I went down there and I started seeing patients in this poor area. And what we were developing was in office surgery. The patients would come in, the students would evaluate them. I would do their surgery in office, no monitoring equipment, nothing, just in office cataract surgery. Then the patients would be seen by the students. These patients were like my patients in Africa. So Javier had been taking care of his mom, and when she died, as she was dying, the last thing she said to her daughter was, "You have to get Javier in to get his eyes fixed." So when she brought him in, she literally was holding onto his hand and leading him in. He had bilateral white cataracts. And so the
Mm.
day after his surgery, when they were driving in, the first thing he notices is that when she turned off her car, goodbye came up on the dashboard, and he said, "Your car, it says goodbye." Didn't say it, but there was the word goodbye. She was so excited. She
Sure.
was crying. He was crying. It was amazing. And then we subsequently did his other eye. But there's a little woman in the village in Sierra Leone. Her son, I did his first eye when he was 6 or 8 months, and then on the next trip, I did his second eye. And so after the second eye was done, I saw her standing outside of the operating room, but I was so busy running between the clinic and the operating room, I didn't really have time to stop till the end of the day. So I went to her at the end of the day, and I said, "I'm sorry, it's just been so crazy. What can I help you with?" And she just started crying and crying. And she said, "You've restored the sight to my son. What you have done, only God can thank you for." And it was
Um,
just so heartfelt and so, it was just so beautiful that that she truly felt that this was, I mean, I believe that God does all of this. So that was amazing. I also had a patient who had been in a nursing home, and her sister brought her in and said, "This is," and the nursing home patient was like still in her pajamas with a little house coat on, and the sister who came to visit said, "This is not my sister. My sister would normally have makeup on. She would be interacting. She would be," and I examined her, and she had like bilateral white cataracts. And I said, "Well, she can't see
yeah.
anything." And so I said, she wouldn't respond to me. She wouldn't talk. She wouldn't do anything. And her sister said, "I'm sure it's because she can't see. She can't see to eat her food. She can't see to do anything. I am begging you to do her surgery." And I said, "But I don't want to do unnecessary surgery. If I don't feel like I can get somewhere, I don't feel like that's proper." So the sister talked me into it. I did her surgery, really feeling like this was not the right thing to do. But when she came in for her post op, she was dressed to the hilt. She could see everything. I mean, now her world had opened up again. It wasn't like she was all closed in, like she couldn't do anything. It was just
Wow,
amazing. I
that's
have
So,
gotten
beautiful.
very
Kathy, how often during a given day or week do patients come up to you just so thankful for what they've experienced from your hands?
pretty frequently. Very frequently. And that gives me a chance. That gives me a chance to say, God is a great healer. Let us give the glory
Yeah.
and praise to our Lord. So that's
Mm.
my little faith flag. So I can just throw that in. And it's since I do a lot of surgery, I can say that again and again. And it only takes me, 30 seconds. I'm not taking a long time to evangelize. I'm just saying, God is who's responsible for this. Let's give God the glory and the praise. Now, let me take a look at your eye. And so, um, let me help God out a little bit here. So, but once in Africa, I had a patient say that he was going to marry me. So after he had his surgery, he said, the doctor, I want to marry the doctor." And my husband actually videoed this guy saying it, so because he got such a kick out of this guy being adamant that he was gonna take me home and he was gonna marry me. Ophthalmology is so rewarding. It is so rewarding, especially like in Sierra Leone when I do my mission work. And I know you don't want to talk about this a lot, but when they come in and both eyes have cataracts in them, they're led in. That means that someone has to be their caregiver around the clock. So while the rest of the family's out working in the fields, either a child is not going to school or one of the adults who would be working in the field is taking care of grandma because they have to take her out to the bush so she can pee and bring her back in. They've got to give her food. They've got to take care of her. So if I do just one cataract, I can free two people. So
Wow.
it's an amazingly rewarding thing to do over there.
And that's a little tease because we're set up in about 2 months to interview Cathy on her mission work. We haven't done a mission episode for 3 years, and it's going to be great. But now back to the quote normal world of ophthalmology
Yeah.
in the United States. But Cathy, we started talking about Catholic beliefs. Are there any particular ways that you think that ophthalmology has any ethical concerns in it that you especially notice because of your Catholic faith? Or is this one of those fields where that really isn't a problem?
Well, there can be a problem. For example, if a patient has a friend who had an upgraded intraocular lens and they really want that because their friend, their neighbor, their uncle, whatever, had it, but because they've got retinal pathology, they're not going to have a good outcome. I think it's
Mm,
morally wrong for me to put an upgraded lens in somebody that I feel has pathology that would prevent them from getting the best result. So that's
mm,
sort of an ethical issue. There's also the retina doctors use different types of the anti-VEGF for
Hmm.
things that are bled in the eye, like diabetes or vein occlusion.
Sure.
And there's a real cheap one that's Avastin, and there's the more expensive like Eylea. And I know that there's been some times when I've heard of some retina doctors charging for the expensive one, but using the cheap one, which to me is
mm,
Ooh, wrong.
obviously objectionable. But they do that. But for the most part, it's really a very positive. I mean, if people come in and they've lost their sight due to something else, I can't. I don't have any Lazarus power to raise them from the dead. But for the most part, the things that we do, cataracts straightforward. Glaucoma can be difficult. Treating diabetic retinopathy, if they're not controlling their diabetes, that's
mm,
difficult because you got to systemically control that. The same with hypertension, high blood pressure, that's got to be controlled. And so there's things that we can make a difference in, and there's things that we really need the patients to help us make a difference.
mm.
Um,
So, Cathy, what do you think are some misconceptions, if any, about ophthalmology and ophthalmologists?
okay, so this is something I hear all the time. I heard you're going to take my eye out. You're going to lay it on my cheek. Have y'all heard this too? You're going to lay it on my
Yeah, because the
cheek.
optic nerve really stretches. Yeah.
Yeah.
And then you're going to cut it open and just pull that cataract out. And no, no, no. So then you tell them about the little tiny incision you're making and the implants all folded up and it goes inside of the eye. That's the one. And the other one is they often think, just like the scales on St. Paul's eyes, they think that the cataract is a scale on the front of their eye, and I'm just going to scrape that baby off. And
Mm.
that's not the case. So, those are probably the biggest things as far as misconceptions with regards to ophthalmology. Sometimes they come in, wanting their cataracts out, and when they really have something else, like they maybe have a retinal detachment, and that's really what they need getting fixed,
Ooh,
that
Sure.
can be
yeah.
very disappointing, because they're coming in going, I heard that you do a lot of cataract surgery and I think this is great, yada, yada, yada. And I can't wait to get my cataract surgery done. And then you go, I'm sorry, I'm not going to be able to help you. We need to see the
Mm.
retina doctor to get this taken care of. So,
Wow.
sometimes that can be really difficult to tell those stories. And, and I know we're going to do Africa later, but sometimes the kids that come in with tumors that I see in Africa, I can't help
Mm.
because I just don't have what they need.
Kathy, that's a good segue probably into sort of understanding the difference between ophthalmologist, which is a hard word to say and spell, and optometrist, a commonly used word. Tell us a little bit about optometry and optometrist, and when should a patient see an ophthalmologist versus an optometrist?
That's a great question. The optometrists, who are now trained so much better than what they were in the past, are great for primary eye care. So your routine eye exams, even for your glaucoma checks, it just depends on how much of the equipment to evaluate the eyes. So if a glaucoma patient needs to have a visual field and the measurements of their nerve fiber layer, I have some optometrists who will send the patient to me. We do all the big studies, but they'll check the patient's glaucoma pressure, the eye pressure, like a couple of times a year, then send them back to us to do that additional testing, and then it goes back to them. So many of them can monitor that sort of thing. They're far better at glasses, contact lenses, and that sort of thing. And now the whole world of contact lenses has changed. So
Mm.
there are certain eye problems where I need somebody who's good with contact lenses to fit somebody. So if somebody has keratoconus, which is where the cornea is real steep, there's certain contact lenses that can help them with that. Or somebody
Mm.
who might have ocular surface disease where their corneas are so dry, you can get a contact lens that has like a soft surface and then the rigid part so it holds the tears in there and keeps their eye lubricated. So they do a lot of things like that. Most of them are really, really well trained. They can pick up retinal problems, they can pick up diabetic changes, things like
Mm.
that. And then they refer them into the ophthalmologist, who will be the one who does the surgery or does the treatment. But oftentimes we co manage. So if I
Sure.
do a patient and do their cataract surgery and see them at one day and everything looks okay, and they've traveled an hour and a half to see me, and they're going to go back to their optometrist who's 2 blocks down, that just makes more sense.
Wow. So, Cathy, in the time we have remaining, Tom and I spend a fair amount of time with students, maybe pre-med students and med students. So, if they happen to be listening and maybe they're entertaining the idea of ophthalmology, what would you have to say to them about that potential decision?
Oh, I think they should don't even think twice. Just come right in. Have it. If they, if any of them are in the area, Pennsylvania, come and I have students watch me all the time, and I'm happy to have them both in the clinic and in surgery. And we've got great monitors in surgery, so they can really see well what's going on in the clinic.
Mm.
They can also see how the patients are managed. We actually have a program here that's called the Heroes Program, and they let the students come in both high school and college. And so
Mm.
it's great that the whole they go across the board to look at different specialties. But yeah, if you have somebody who's thinking about it, if there's somebody that they can shadow for a day or two and just get a feel for it, that's what they should
Mm.
do. I think to just and regardless of what specialty, I think that's always helpful.
Well, Cathy, you've opened our eyes to ophthalmology. Any final comments you might have for our listeners?
Yeah, actually, I just would want all the listeners to realize that our sight is just such a precious gift from God, and it's their
Mm.
responsibility to protect them, protect our eyes. When you're out working with your weed eater, please put safety glasses on. If you're working under the
Mm.
car, I just this weekend I removed two rust foreign bodies. So please protect them. Also, please get routine eye exams, things that can be picked up so early. So, macular degeneration, we can pick up now on an OCT before we can see it clinically. When I was in training,
Mm.
that was
Ooh.
impossible. So, we could get them started on the vitamins and a healthier diet and UV protection and stop smoking and prevent them from getting to the point, maybe, on those healthy diet and
Well,
stop smoking.
Cathy, you've been a terrific guest. We can't thank you enough for spending some time with us and with our listeners, and we can't wait to have you back on Dr. Doctor. Thanks for joining us.
Thank you so much. It's great talking to you guys. Bye.
Welcome back to Dr. Doctor. I hope you've seen your way to join us on this episode describing the specialty of ophthalmology. And now it's time to get back to the answer to this episode's medical trivia question, Tom.
So, out of the 12 pair of cranial nerves that go directly from the brain to an end organ like the eyeball, the tongue, the skin, muscles, how many of those 12 are related to vision and eye function? And I may hasten to point out that our guest corrected me because I had the wrong answer written down. I was not thorough enough. So the answer is actually 6, half of the 12 cranial nerves. Cranial number 2, that that mnemonic on old Olympus, towering top of Finn and German viewed some hops. That's the first letter in each of the 12 cranial nerves. So old is the optic nerve, vision itself. Olympus is the oculomotor nerve, which moves the eyeball in certain directions. The T is of towering is for trochlear, another muscle of eye movement. Then you got the trigeminal nerve, which does a bunch of stuff, but including sensation and action of parts of the eyeball itself and the skin of the upper eyelid. Then before a fin in German is for the abducens, another nerve that moves a muscle to move the eyeball. And finally, the facial nerve, which does a bunch of stuff, but including some of the muscles used to close the eye. So 6 of the 12 cranial nerves are involved with our eyes and their function.
I mean,
Wow.
they're very important in our day-to-day function, the 12 cranial nerves. And then most medical students will remember it's almost a rite of passage to memorize the 12 cranial nerves in gross anatomy class.
Amen. And Chris, our 3 top takeaways for this show.
Well, there's a bonus takeaway. One is I wish that I had 10% of Cathy's energy.
Yes.
That would be great. But beyond that, I love when she said, God heals, we help. Now let me look at your eye. I love the way that she said that. And then equally beautiful, she said, our sight is a precious gift from God. Protect it. She referenced wearing protective eyewear if you're doing anything where foreign bodies could fly into your eye. And that's so easy to skip, but so important to do. And then finally, I think we need to all be reminded that care for your eyes, take care of them. Sight is so precious. So get routine eye exams with a good optometrist. Find things early so they can be treated more effectively.
And Cathy told us she's getting ready to take another trip to Sierra Leone. And if you want to learn more before we do the episode on her, the website is www.thegiftsofsarabu.com. That's THEGIFTS of OF Sarabu, SERABU.com. But we're going to learn about it more in a few months with Cathy.
Yeah, she was really remarkable. And it's just such a great, it's so wonderful to see someone so excited about their specialty, having done it so many years and touched so many people's lives. It's a wonderful thing to see.
Amen. And Chris, listeners, thanks everybody for being with us for another episode of Dr. Doctor. You can find this and all our old episodes on our website, drdoctor.org. Just click on episode archive at the top where you can search over 260 episodes by topic or guest.
And if for some ununderstandable reason you want to see us, instead of just hear us, we now have our shows on our new YouTube link. Go to the top of drdoctor.org and click on that YouTube button. If you have a question or an idea, send us a note. Click on Submit a Question. We'd love to hear from you.
This is Dr. Tom McGovern.
And this is Dr. Chris Straub. We're signing off until your next dose of Dr. Doctor.